So we'll talk about those individually. Okay. Um, I would love it if everyone would say that, oh, yes, I listened to the lecture already, but I do understand if you hadn't. Very good. I saw somebody's thumb go up. Yes. Because if you listen to the lecture, this is pretty much activity. The lecture is already out there. I'm so thankful to see you all come. The activity is just to kind of bring the lecture home a little bit. You may record. I don't know if it'll help or not. I usually don't record activities because we're at least in and out once. So if it works for you, that's okay. You're welcome to record. As far as questions, I'll try to give you all some time in between. And because it's more of an activity, you probably can ask your questions when you need to, especially when you're working out the case study. Okay. All right. Just making sure somebody was trying to get into Zoom. They found it. Okay. So we're going to start off by an activity that was on the recording already. So I'm going to share my screen with you guys. Someone can open their mic and answer. Can you all see it? Yes. Can you all see the screen? Thank you. Appreciate it. Okay, this was one of the pre-class activities I want to go over with you all to see if you, because this is basically a refresher for you. You had this in, I believe, in chemistry. Well, not, y'all didn't do chemistry, but I'm sure you had it on your earlier levels. So, anybody can answer. Okay, we're looking at the normal osmolality, which is 285 to 295. As I said in the lecture, I use Uganda and Uganda because the two books that we use, I don't believe their numbers are in sync with each other. So can somebody tell me, since this is normal, what would you expect the cell to do?
Stay the same size.
Thank you. Thank you, Justin. Right, because it's normal. It's in hemostasis. So as far as a fluid choice, if the fluid status is what? When in reference to dehydration or
isotonic?
There you go. Fluid volume overload. They're isotonic. They're in a balance. They're in homeostasis. So normally you're going to use an isotonic solution. Very good. All right. Let's look at the lower osmolality. Someone would answer, what would happen to the cells?
Shrivels up.
This is the low osmolality.
No, they were lice.
They would blow up. Just think, the best way to do this is to think about when you got a fluid, too much fluid, because your osmolality is too low. So when you got too much fluid in a balloon, it just swells until it ruptures. All right. So what is the fluid status of this patient, which I just said?
Fluid volume overload.
Exactly. This patient is in fluid volume overload. What type of fluids do you think you would use with this patient?
Hypertonic.
Hypertonic solutions, right. A great example is D5 normal saline, 3% saline. It just depends on the patient's sodium. So thank you. Appreciate your answering. All right, Ebony. Back to you. High osmolality. What you think will happen to the cells?
Shrink.
With high, it's just to shrink them.
There you go. There's your shrinkable cells, right? Because what's happening is the fluid is being pulled out of the cell because there's not enough fluid in the cell. It's too high a concentration of solutes in the cell, so it's going to pull out. Okay. So this cell going to shrink. What type of anybody? What is the fluid status of this patient?
Fluid volume deficit.
Right. Fluid volume deficit because we don't have enough. What type of fluid you think we would use with this patient?
Oh, like an isotonic? A hypotonic?
Hypotonic. Isotonic could be used, depends on the physician or whoever, but definitely hypotonic. All right. When we get to the DKA and the HHS, sometimes you're going to see both fluids. But just to keep your head clear, you expect to use a hypotonic solution. All right. So isotonic is used when there is the fluid status is normal. You can use isotonic solutions. So as not to trick you up, I don't want, when I say the patient has a fluid volume deficit, more than likely they have hemo concentration, meaning their numbers are probably going to be up, like your sodium and different things like that within the test. And if the sodium is up, then you're going to use a hypotonic solution. Now, you notice at the end of the page right here, this is the formula that it's very important that you know. And I gave 2 examples. And I want you all to take a minute and work the first one. And then we'll discuss the first one. And then after we discuss the first one, you all work the second one and we'll discuss that. So if you would just work out that formula and tell me what you come up with. And I'll ask you a few questions from it. How are we doing? Okay. Can you all hear me?
Yes.
Okay, thank you. So, can someone tell me for number 1, what answer did you come up with?
321.
Anybody else?
I got 321.1.
That's what I got.
Okay.
I got 314.8.
All right.
361.
Yeah, 321.
I have 321.14.
Okay, I have 321, and maybe I didn't tell you all, but just round it to the whole number. It'll be shown to you when you do the case study. So I have 321. But they're all, one thing about it, they're all what? They're all greater than 95, right? 295, correct? So since they all greater than 295, the osmolality is considered high. So with this patient's fluid status, dehydrated or fluid volume overload?
Dehydrated.
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 Great. What fluid replacement should we consider?
Hypotonic.
Very good, thank you. If anyone had trouble with that, you're welcome to, well, today I only have about, I think, an hour of office hours, but at the end of the day, if we don't use the whole hour, that'll be a good time for us to go through it and work it out. Okay, work out the second one and see what numbers you come up. Can you see it?
Miss John.
Yes.
So because they need hypotonic solution, that would be like just normal saline.
Hypotonic. Half normal saline. All right. Let me turn the volume up because I can hardly hear. All right. Thanks for asking that question and clarifying. All right, so let's work the next one. Okay, I see a few heads up. So, what did you all come up with the answer this time?
67.
267.
267. Very good. All right. So, according to the readings or the values up here, is this high or low osmolality?
Low.
And when it's low osmolality, that means the person is what?
Fluid volume overload.
Very good. So, what type of fluid would we probably use? Hypertonic. All right, so if I was to ask you which fluid maybe would not be a good fluid to use for this patient, which one would you tell me of the tonicities?
Hypotonic.
Yes, I would use a hypotonic solution with this patient because we already have too much fluid on board, and that's just gonna make it swell more. Very good. Awesome. Okay, so let's see. Let's stop sharing for a minute. Okay. Okay, so you all did well with that. I believe we're going to go to the case study next. So we have a case study. If you have not had a chance to listen to the lecture after the test, please make sure you listen because a lot of information is in it. This is to help you to somewhat bring it home to be able to actually implement what the lecture is about. Well, not the full lecture, but a great part of it. All right? The full lecture is about an hour and 17 minutes. And I'm thinking someone thought it was this Wiggins yesterday because they told her she had one and she said, well, she did it in her sleep. So that might have been mine. Okay, so let's see. Let me share the screen with you all again. Now, unfortunately, I'm going to have to ask you all to do like Miss Wiggins yesterday, and that's take a picture of this this page. Normally, when you're in the classroom, I give you copies, but this is not good. I had not been able to figure out how to share the screen in the breakout. I can't find it. Maybe somebody later on will teach me. But you take a picture. You're going to be placed in groups. You're going to process the information that you have on this patient. You see the questions below. 1, 2, 3, 4, 5. You're going to answer those. Your ABGs. Make sure that you tell me if it's the patient acidotic or alkalotic and whether they're metabolic or respiratory. I'm not going to press you with the compensation. I don't believe Dr. DeLima is going to do that. So I'm not really testing on this material, but this is important to this case. So I need everyone to take a picture of it. Now, I will do a breakout. And if it asks you, just click on join if you get this blue button. If not, it might put you directly in the room. I will make rounds in the room to see if you need my assistance. I'm not sure how the help button works. The question, I think there's in the breakout room, I think there's a question mark. And I believe I can probably come to the room but I'm going to pass through there anyway, just to kind of help you all to process this and think it out. So, before we break out, does anyone have a question?
Are we answering all of these questions, or is each group getting a specific question?
Everyone in the group, we all answering this question. As far as a spokesperson, if you want to elect a spokesperson, you can, but everybody's working on every one of these questions. And whatever your group comes up with, then that would probably be the answer for your group. Because when I ask you the question, I don't know if I'm gonna ask you about the APGs. I don't know if I'm gonna ask you about the lab values. Not sure which question I'll ask, and multiple people can answer the question. But I just want you all to get together to work this out. That was a great question. Thank you. Any other questions? All right. Let's see. Did everyone get a picture of it? So I'm gonna stop sharing. Okay. All right, someone, let's see. So we're gonna create rooms.
Not prepared for this.
Mm-hmm.
So I wish we knew her calcium, because I don't know if I'm like looking too deep into it, but I feel like she has high calcium levels based on the the muscle pain. Because I know that with metabolic acidosis, they have high calcium. So I'm trying to see where like the muscle pain comes from.
Did anyone write down the equation for finding the osmolality? I did not write that.
It's 2 times the sodium plus the glucose over 18 plus the bun over 2.8.
You got it, Hannah?
Trying to put it all in my calculator on my phone, but I'm having to go back and forth.
I'll send you a picture, Hannah.
It's the glucose is divided by 18.
Yes. I got 339 for the osmolarity.
For question 1, the map is low. The map calculate is 66. The normal range should be 75 to 100. And the temperature is high. And the heart rate is high. And from the physical assessment, so you can see they have the poor perfusion. And from the lab value and glucose is high, and BUN is high, and WBC is high. And the magnesium, let me check.
Magnesium's normal.
Yeah, magnesium is normal, sodium normal, potassium is normal.
Where are you gathering that their perfusion is poor based on the physical assessment?
Well, you can see they have poor thready pores, dry mucus, poor skin, turgor, and
I didn't read that sentence. I did
yeah.
the map. The map isn't that at all.
Well, MAP is a little low, so it's 66. The normal range should be 75 to 100.
I thought it was 70 to 100.
Well, that's our textbook normal, but like most hospitals, people don't really worry about 66 too much.
Oh,
Like,
okay.
A lot of hospitals
but from the physical assessment, so that shows
Yeah.
that they have a poor perfusion though.
I think we figured out what number 1 is, that the important stuff. What do y'all think is the immediate concern, and why?
The blood sugar is too high. It's kind of like how you call that name, the HH whatever for diabetes 2.
DKA.
No, not this is diabetes 2. DKA is diabetes 1. So this is HH what? So they mentioned it in the
HHNS.
yeah HHNS. That means very high glucose level. And probably the kidney is a problem because the BUN is high, and also had an infection though because the temperature and the WBC is high.
So we're just supposed to sit here until one of them comes in.
So from the ABG, there should be respiratory acidosis, just because I think it shows the compensation of the metabolic acidosis. So they have to. Oh no. No, let me check. No.
Metabolic acidosis. Did anybody else have that?
Yeah.
Oh. I saw the wrong numbers. Sorry.
So we said the concern was basically like blood sugar and dehydration.
An infection, I think. Yeah, because the temperature and the WBC is high.
Okay. Yeah.
Well, I wouldn't call that the immediate concern though.
Right.
I would
I think the
definitely,
blood sugar.
The blood sugar, yes.
that's
Yeah.
an immediate concern.
What do y'all want to do with prioritizing care and including rationales?
Avoid it.
So give her insulin, IV push, 0.1 unit per kilogram, and she gets put on an insulin drip.
Probably some fluids in there.
Yeah.
And then I think, I don't know if you do insulin first and then fluids.
I feel like they'd be able to run simultaneously, no?
Yeah.
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 So they would be hypotonic solution.
Yeah, because 330. So it was likely that the HHS was brought on by an infection.
Yeah.
Yeah.
And also I think the kidney probably has a problem because the BUN is high. Also the urine turned to the dark color.
Yeah, but couldn't that be from the fluid imbalance?
Well,
We're not getting their creatinine level here, so it's hard to figure out if the bun's altered due to the fluid status or due to renal damage.
Yeah.
I think it's more fluid status.
Yeah, that's what I'm thinking.
What's the osmolality? The number?
I got 339.
339. It's high, right?
Yes.
I think after the insulin and fluids, then you would do a culture for finding out what kind of infection they have.
Yeah. And then monitor their electrolytes because
Yeah.
rehydrating them, it can cause hypokalemia.
Yeah.
So like
I would say eyes and O's too for fluid volume overload too.
Mhm.
and obviously since she's on the insulin drip, we're gonna like check her blood sugar very often.
Mhm.
I don't know if there's like a protocol for that or what, but probably like at least every 30 minutes.
So we need to give to the hypertonic flu.
Hypo.
Hello. Still working on it?
Yeah.
Okay, all right.
Would y'all do anything for pain?
I think so, if she got pain.
Yeah.
Well, I don't know if I would automatically just go ahead and give her pain meds right away. I think I would give it just a little bit and wait and see if the headache goes away as we're correcting things or not.
Yeah,
Like,
I think I
once
would
we
wait
start-
on some fluids, yeah.
Yeah, once we start everything, if she's like, if she's still having pain after we've brought the insulin level or the glucose level down and corrected the fluid imbalance some, then I would get pain meds, but it wouldn't be at the top of my priority list
Well,
right off the bat.
So we could do Tylenol for that, and
Yeah. I would say I would reassess it maybe halfway through that, maybe like 30 minutes into, like you said with the AccuChecks, Emily, maybe around that time.
Well, the AccuCheck would be ordered, right? That's a protocol or an order
with like insulin. Yeah.
for the facility or the doctor.
Do you really need an order for an AccuCheck? I mean, can you not just do it?
It is an order. It's on the MAR.
Yeah. Is metabolic acidosis a cause of HHS? I'm not really sure. HHNS?
no, I think it's just the diabetes too.
Because whenever you don't have insulin, it causes the lipids to start breaking down, and that releases acids.
Okay. So that should kind of correct on itself then.
Infection that she has.
We're getting kicked out of here, guys.
Hannah, would you like to speak for us?
No. I didn't prepare for this. I didn't even know there was a lecture posted for this.
We'll
I'm
be
taking
fine.
off.
For the whole class will do it anyway, so I don't,
Yeah, I'm just
somebody will do it. Jordan looked prepared, and I forgot the other girl's name.
right. I didn't even fully read the paper when we started this.
We'll be all right. All right.
I looked at numbers. I get past the numbers.
All right, see you guys later.
All right. Everybody should be back now. So let's look at the scenario first. We're looking at a 50-year-old, let's see, who has been diagnosed with type 2 diabetes. Chief complaints, severe muscle, the triage, assessment reveals fever, fatigue, headache, menorrhea, vital signs, okay. Okay, and anyone can answer this question? When looking at her presentation to the hospital, when you think about DKA and HHS, which one do you think this patient would be in?
HHS.
HHS, very good. And this patient is definitely in HHS, and multiple things will point toward it. What are some of the problems in assessment that would make you think she's HHS?
They have a history of type 2 diabetes and a glucose greater than 600.
Very good. All right. And those are the things that you'll hear also in the lecture, that the glucose is relatively high. Let's see. Let me look at my questions before I just start. Okay. So number one, what information is important and why? Who wants to take that on?
Are we going in our group order? Or just anybody?
Just anybody.
Okay, I'll take it.
The group was basically just to get you all to kind of share your ideas and work together.
Okay.
Yeah.
Perfect.
But you know,
Information.
I know how it happens. You know, I don't want to speak. Yeah. Okay. So go for it, Nicole.
Information that's important, obviously the blood sugar of 700. Vital signs, you have a blood pressure and a heart rate going in the opposite direction. Their MAP is below 70. Their BUN is 28. The muscle pain. What else? Yeah, so all the things. The muscle pain, the fever, all of the assessment data is very important.
Okay, so you might have said it, and I might have got distracted. Did you say about signs and symptoms of respiratory infection?
I didn't say the infection. We came to the agreement in our group that they were in metabolic acidosis and possibly respiratory alkalosis. They probably had two things going on there.
Okay.
They also have they're breathing rapidly, and
Right.
they have a temperature of 101.4. That's a fever with a high white blood cell count.
Okay, thank you. Very good. So, the second question, and we're going to break in about 5 minutes, so let's try to answer the second question. What is the immediate concern after obtaining the lab values?
Well, you can see that the patient is going septic on you. The group that I was in, we came to the conclusion probably metabolic acidosis related to sepsis. The kidneys are failing because the BUN is at 28. The white blood count is 15,000. So let's see what else. We already mentioned the glucose at 700. So probably that patient's going to get an insulin drip regular. O2, of course, because that respiration is increased at 24. Hypotonic fluids like half normal saline. Treat the infection, antibiotics.
All right, it sounds like you're answering all my questions.
Oh, I'm sorry.
I mean, your group has done a great job. That's all right. Let's someone else. Can you tell me what you came up with the calculation for the osmolality?
339.
339?
Yes, ma'am.
Did everybody get 339? That's correct, because I think I told you all to round it off to the whole number. All right. And on that note, we're going to break. Be back at 9:30. Thank you. And I'll look at the chat and see if anybody asking me something.
Miss Jean.
Yes.
How did they get 339? Because I'm not coming up with the same numbers for whatever reason.
Okay. Let's see. What's our number?
I multiplied the sodium 2 times the sodium,
which is
number,
145.
Plus
right?
plus
and what you came up with?
um, 310.
You came up with 310? Let me get my calculator.
That's too high. It should be 290.
Wait, 2 times.
Let me get my calculator.
Um,
2 times
I don't know.
145?
Yes,
Right.
yes.
It should be 290.
All right, so I have the 290.
All right.
Then I added the 700.
No. You got to divide the 700 by 18.
Oh, okay, that's what I'm doing wrong. I'm not dividing the glucose.
You work out everything, and then you add everything together once you work it out.
Okay, all right.
See if you
That's
come
what
up with the answer. Okay.
Okay, divided by 18. So the 18 is a standard number. You divide everything by 18.
Right. You remember I gave you I showed you all the formula earlier.
Oh, all right. That's what I was doing wrong. All right. Thank you.
Ms. Jean.
Yes.
Sorry. So quick question. I was just kind of looking over some things from previous semester when we were looking at DKA. Granted, I know that this patient is type 2, so we're not looking at that. But when treating a patient with DKA and the patient's on that insulin drip, we're also watching their potassium and that potassium shift. Would we still be doing the same thing for somebody in this hyperosmolar state?
Yeah, but don't jump the gun.
Okay.
But you're absolutely right. You're very concerned about the potassium.
Okay.
All right.
Michelle,
Yes, ma'am.
were you in a lecture, the acid-base lecture when we did it?
Yeah, I was in there.
Never mind.
You can go ahead and ask. I mean, any questions in regards to it, you probably have to take it to, I think, Ms. Hopkins.
That was Dr. Delisma. I'll ask her.
All right.
Thank you.
Mm-hmm.
Miss Jean, I'm sorry.
That's
I didn't catch all the equation. I know I have 2 times sodium plus the glucose, which was 700, plus the BUN. But I also have, I don't think I took the full picture.
Okay, I'm gonna try to put it in the chat box for you, so you
Okay,
can see.
Because it's BUN divided by 2.8, or is it the
BUN divided by 2.8?
Okay.
The glucose is divided by 18.
Okay. Oh, I'm thinking dividing the whole equation by 18. Okay, gotcha.
No, Yes, 2 times the sodium plus the glucose divided by 18 plus BUN divided by 2.
Divided by 2.8. Okay.
Thank you, Jordan.
You're welcome.
You young people type so much faster than I do. Step away for a minute.